So next question states that there is a 19-year-old man who was presented to the emergency with a gunshot wound around the umbilicus. The systolic blood pressure is 70 mm on palpation and his abdomen is slightly distended. Now till now we have established that the patient hemodynamically is unstable, and after this now we have to see that what the question is demanding from us. Large IV lines have been placed. Now they are asking that what should be the next step. So in gunshot scenarios, stab wounds or RTAs, you have to make sure that you follow a specific algorithm. And the very first step in the algorithm is to define whether the patient is unstable or stable. After that, I will explain this in the diagram as well. Once you have established that this is the patient is stable or unstable, it will be very easy for you to follow the next step. So in a patient who is having gunshot wound and is unstable, we will definitely be going with the exploratory laparotomy. Even you do not have to read the MCQs, this will save you from getting confused. However, the other options include peritoneal lavage, CT scan, transfusion of the patient, and PASC. Now, CT scan can be an option only if the patient is stable. So, there are all the options which are available for various scenarios. So, if the patient is stable, then we can go with the CT scan. But if the patient is unstable, we will go with the exploratory laparotomy. So, let's go to our flowchart to get better understanding. So, these are my handwritten flowcharts. They are definitely going to be helpful. So, in the case of a trauma patient, whether the patient is stable or unstable, we will follow through this flowchart. So if the patient is stable, then we will go with the fast scan, and followed by that we can go with the CT scan. Now CT scan is much more sensitive and specific, and in terms of the MCQs, you can skip fast scan and directly choose for the CT scan. If the patient is stable and their fast scan is negative, then we can go with serial fast scan or we can just observe the patient. But on the other end, when the patient is hemodynamically unstable and either the fast scan is positive for any bleed in the peritoneal or the different compartments of the abdomen, or even with the negative fast with the presence of signs of peritonitis, we will directly go with the exploratory laparotomy. If the patient is unstable and there is a negative fast, then initially we will do the heavy resuscitation of the patient and try to find the cause. So if you follow the algorithm that what is the step where you are placed in the MCQ, then you can follow this diagram in your mind or in your notes to get to the answer. So the remaining explanation is about the damage control surgery. It is immediate and temporary repair for life-threatening injuries, which is followed by resuscitation in the ICU and definitive care later on. Now, the most important component of damage control surgery is hemorrhage. So, hemorrhage is the thing which is dealt first, and it is followed by any visceral damage, viscera being damaged. For example, in the liver or spleen, they can be removed, or in the liver, they could be liver packing. Now, contamination is dealt after hemorrhage has been restored. So next up we have a 34-year-old man brought to the emergency with a large open knife wound to the left thigh. Alright. So the patient's systolic blood pressure is 90 mm of mercury. Blood is spurting from the wound. What will be the initial management step? So again, in this scenario, we will try to follow the ATLS protocol, that what step is being followed. So would it be clamping the bleeding artery? Tourniquet 7.5 cm above the wound, apply direct pressure, apply PAST and inflate both the legs and insert a central venous line. So whenever there is a spurting vessel, it comes into the small C part, that is the extravasation of a hematoma, and later on it is followed by the A, B, C, D and E. Now, in the latest guidelines, it is very important that the spurter or the bleeding vessel needs to be controlled. Now, it is controlled by certain steps, and the very first step is to apply direct pressure to stop the bleeding. Now, this is followed by application of tourniquet and various steps, which I will explain with the help of a flowchart. So I've also explained this part in the initial assessment of trauma video. You can also consult that to have a good understanding about the ATLS guidelines. So here I have explained that the control of the external hemorrhage algorithm. So first of all, we have to put pressure by hand or by balls. Then the tourniquet is applied as a second step. So this is the first step. Then tourniquet is second step, and then we have the ligation or laparotomy if there is a bleeding vessel in the abdomen. Now, tourniquet should not be applied more than 60 minutes. That's an important key point in this scenario. So next up, we have a 40-year-old construction worker is called from a rubble after a building collapse and pins his right lower leg. Now, X-ray in the emergency reveals a comminuted fracture of the right tibia and fibula. The dorsalis pedis and the posterior tibial vessels are palpable or wide. So it's a orthotrauma MCQ in which there is a comminuted fracture and the pulses are present. The patient complains of severe pain that is increased with a dorsiflexion of the foot. The calf muscles or the calf area feels tight as well. So what is the appropriate step? So would it be ORIF of the fracture, that is the open reduction and thermal fixation, or ORIF plus 3-compartment fasciotomy, close reduction and observation, open reduction and fixation only if the vessel becomes P, or an arteriogram? So this is a clear-cut scenario in which if you're asked about the diagnosis, then the diagnosis would be compartment syndrome. Now, in the compartment syndrome, it is always important to go with the reduction of the fracture as well as fasciotomy. The fasciotomy is very important surgical step in the management of compartment syndrome. So, a tense calf muscle with comminuted fracture and pain on dorsiflexion shows a high probability of compartment syndrome. So let me talk about more in detail about what is compartment syndrome and how it should be managed. Now, regarding compartment syndrome, we need to know the 5 P's, that is the pain, pulse, failure, paresthesia, and paralysis. A patient is going to have pain that is going to be out of proportion. Pain will be there even after you have given them analgesia, and pain will be there. Pain will be positive on passive stretch. So these are the 3 points which are the giveaways that any one of these points are present regarding the pain after a fracture, then you will definitely be suspecting compartment syndrome. Now, pulse can be absent and it is a late sign. Similarly, as in absence of the pulse, there will be less blood going to this area and it will start turning pale. Now, in addition to the compression of the blood vessels, when the nerves get compressed, then the sensory as well as motor response will be visible. That is loss of sensation and eventually loss of the motor function that results into the paralysis. So this is the diagram of the leg showing the 3 compartments. In order to understand compartment syndrome, we must also be aware about the anatomy. There is an anterior compartment, a lateral compartment, and a posterior compartment. So I will explain their detail when I will explain the incisions which are required to manage the compartment syndrome. So now, what is the algorithm to manage compartment syndrome? So first of all, you have to recognize what are the early clinical signs to diagnose compartment syndrome. So there are 6 P's and they're not all reliable. So I have written them down that out of these 6 features, which are the most important features. So pain out of proportion is one of the most reliable signs. I have explained this in detail. Now, paresthesia is an early neurological deficit. It is a plus minus. It can be important, even it can be absent, but still there could be compartment syndrome. However, Baylor paralysis and pulselessness are the late sign. You cannot rely on these signs to diagnose your case because it will result into an irreversible damage to the lower limb or any area which is being involved as a compartment. Now, the second point which is important is the pressure in the compartment. That is going to give us a very important clinical giveaway of the compartment syndrome. Now, pain from the passive stretch of the involved muscle is also one of the very early signs which is not only helpful in terms of solving an MCQ, but in our clinical practice, this can be used in order to timely identify compartment syndrome. So then you have to understand that what are the risk factors which are, if present, you should be considering compartment syndrome. If there is a tibial shaft fracture, highly susceptible area for developing compartment is the leg. Then if there is a forearm crush injury, again, the forearm muscles are divided into multiple compartments, and similarly in the leg. So these areas are quite tightly compressed within the fascia. The muscles are compressed within the fascia, and a small bleeding or injury within these compartments can result into compartment syndrome. Now, if there has been a vessel injury and it was repaired, and when the clamps were opened, the blood flow to the distal compartment. Now, that can result into reperfusion injury that can result into compartment. So, as a consequence of vessel repair, fasciotomy is added as a part of the treatment in order to avoid the compartment syndrome. So, that is an important point that must be kept in mind. Now, tightly placed dressings or casts can be one of the features for compartment syndrome. Similarly, prolonged leg compression, especially in unconscious patient who was not aware that there was a pressure on the limb of a patient. Burn is one of the important factors, and in children, supracondylar fracture is also important. Now, once you have identified or suspecting a compartment syndrome, what you should be doing? You should be measuring the compartment pressure. Although it is a clinical diagnosis, but for the sake of theory, you should understand different modalities. We can use needle manometry, that is known as the Stryker device, or we can use the diagnostic method, which has two. We can use either the delta pressure or the absolute pressure. In delta pressure, the diastolic pressure is subtracted from the intracompartmental pressure, and the answer less than or equal to 30 will result into compartment syndrome, whereas if the intracompartmental pressure is more than around 30 to 40 mm of mercury, it is also giveaway. If the suspicion is high, do not delay fasciotomy, and if it can be asked in the form of MCQ that would you be keeping the patient on observation or would you be going for the fasciotomy? So if there is a high suspicion or even a minor suspicion, then going for fasciotomy is going to be a better option. Then the next step is to actually manage the compartment syndrome, and for that we have the fasciotomy. Do not wait for the muscle and the nerve damage that I have already explained, that vessel loss and nerve loss is a late feature. We have two incisions as we have to open 4 compartments. We have a lateral incision and the other is the medial incision. Now, through the lateral incision, we open the anterolateral compartment, whereas to the medial incision, we open the posterior compartment. Now, there are 2 posterior compartments, a posterior superior and a deep posterior compartment. Both are opened through the medial approach, whereas anterior as well as the lateral compartments are opened through the lateral incision in the leg. Now, in the forearm, we can use a volar or a dorsal fasciotomy incision, and similarly in the hand, dorsal incision between the fingers and the carpals can be used to or remove the compartmental pressure. Now, once this has been done, what are the other measures which can be taken? Some of them are taken before, and so if there is a tight cast and there is suspicion of compartment syndrome, then you must remove that tight cast and follow it with fasciotomy. Once you are done with the fasciotomy, keep the limb at the heart level or elevated. It should be elevated. Now, very important thing is that IV fluids should be given in an aggressive way to prevent renal failure developing as a consequence of the rhabdomyolysis. Now, whenever the skeletal muscle is damaged, the cells which are present within these muscles are going to release toxins into the bloodstream. Now, the vessels which are going beside these muscles are going to help have these metabolites. Now, these toxic metabolites are going to go to the kidney, and they are going to deposit within the glomeruli. As a result, the functionality of the kidney will decrease. So, that is known as the rhabdomyolysis, and it results into the darkening of the urine. Now, as a consequence, urinary output should be managed to observe for the renal failure. Now, then we have the post-fasciotomy care, which includes daily wound check, and delayed primary closure is the method used for the fasciotomy incision. Now, you have to look for the infection, renal function, and neurovascular recovery. And very importantly, please document pre and post-operative neurovascular status of the patient. So, this is the flow chart. If you're suspecting a compartment syndrome, assess for pain, paresthesia, and tension in the limb. Now, if any of the risk factors which I have explained is present, then please consider it that there is a high likely chance of developing compartment syndrome. So, what you will be doing? So, you will be weighing the compartmental pressure, and if you have a suspicion, then you will go with the emergency fasciotomy. In the post-op care, fluid, elevation, bone care, and monitoring are going to be the key role. Now, I have added these flow charts. You can add them on your notes. These are going to be very helpful, especially in your last place of revision. So, next up, we have an 18-year-old woman who is 8 months pregnant. She's brought to the emergency. She was hit by a car and now complains of abdominal pain. Her blood pressure is 80/60, which shows that she is hemodynamically compromised. The respiratory rate is 30. IV line has been passed and the fetal heart rate is 160. So, what should be the steps? So, should the patient be infused 2 liters of ringer? Should there be application of a PASG device to stop the bleeding, or it should be followed with the displacement of the uterus to the left, or an abdominal ultrasound, or perform a peritoneal lavage? So, as in this scenario, the most important thing is that there could be a likely development that the uterus has compressed the inferior vena cava. So, the very first step in a pregnant woman presenting with a trauma scenario, always opt for displacing the uterus to the left side. So, this is going to decrease the pressure from the inferior vena cava. Now, displacing the uterus to the left is the first step in restoring the cardiac return in a patient with third trimester who has become hypovolemic, and it is going to push off the pressure from the vena cava. All right. Now, a 60-year-old man is a front seat passenger in a car crash. He is found to have 3 fractured ribs on the right. There is a rupture of the liver. There is a pelvic fracture. There is a right femur fracture and a left tibia. Okay, there are multiple injuries. This is a polytrauma scenario. The patient is given broad spectrum antibiotics and his injuries are managed by surgery, requiring 12 units of blood. So, the patient is likely to develop massive blood transfusion. So, the patient improves initially, but on the 3rd day, he developed hypoxia. That is, the PaO2 value became 55 millimeter of mercury with the development of confusion, tachypnea, and petechia. Alright. So, what is the most likely diagnosis? Is it a recurrent intra-abdominal hemorrhage? Is it a transfusion reaction as the patient has had 12 units of blood? Is it antibiotic allergy? Is it fat embolism, or the patient had developed DIC? So, in the scenario of multiple long cone fractures with the patient developing a triad of hypoxia, confusion, and petechiae, you will always think of fat embolism. Now, fat embolism is a pathology which is followed by the long cone or pelvic fractures. Now, what happens is when the bone breaks, the fat globules enter the blood and they act in a similar way to occlude the blood vessel. So, if this is a blood vessel, the small fat globules will enter this area and will try to occlude the blood. So, if the blood was going in this direction previously, then there will be less amount of blood reaching over to the end organs. Now, as a consequence, the functionality of these end organs are going to be clinically evident. The most important is going to be the brain, then kidneys are going to be affected, and similarly various other systems. There is two criteria which are used to assess the presence of fat embolism. There is a major criteria and minor criteria. You can read through these values. So if there is one major and 3 minor, then it will be fat embolism, or there is 2 major or 2 minor criteria, then you can suspect fat embolism. So in order to memorize it, you have to see that 1 plus 3 is equal to 4, and so is 2 plus 2 is equal to 4. So you have to make the answer as 4. So remember the major criteria, especially if there is respiratory distress, if there is a cerebral symptom, that is the CNS involvement, and presence of petechiae. And you could also see that these are the 3 findings which are actually given in the scenario as well. So you can go through these values as well. Now again, I have made a flow chart to help you in the MCQs. So if there is a long bone fracture, or if there's an orthopedic surgery and the patient was under your observation and within 24 to 72 hours, they develop hypoxia, confusion, or a petechial rash. Now this triad is very important. This is also known as the GERS criteria. Now GERS criteria include these triad. That is, I have explained that previously, that the 3 major criteria plus 1 minor criteria or 2 plus 2 is going to be the key giveaway for fat embolism. So if you are suspecting fat embolism, then you will assess the patient on this criteria, followed with various investigations which include blood gases, CBC, ESR, and CT scan. And if the diagnosis is likely, then what will be the management? Patient will be requiring an ICU admission. They will be requiring high flow oxygen and specifically ventilatory support, hemodynamic support, and the patient should be stopped from any anticoagulants and consider giving the patient steroids as well. And the patient will be monitored over 3 to 7 days because there is no specific treatment for fat embolism so far.